based on the risk of relapse and of course the persistent disease or in the unstaged setting, and mainly defined by the stage at the diagnosis and presence of prognostic factors. Staging, as we all know, has been undergone a recent changes in 2009, and where we won't be looking much into peritoneal cytology or endostromal invasion. The prognostic factors, most of us are aware that it's stage, depth of myometrial involvement, grade, lymphovascular invasion, and of course I would like to point out to the histological subtype. Again and again, much more exciting now. We know that there are different subtypes which will behave differently, more aggressively. We are coming to know about this in ovarian cancer, and we are finding out different targets, and we might have to treat them differently in very near future. And as far as endometrial cancer, we'll know that serous papillary and clear cell are definitely high risk histology and may need or benefit from adjuvant chemotherapy. But interestingly, I'll come to later how we are basing all this as of now, whether it is really evidence-based. Age is a very robust prognostic factor as far as endometrial cancer is concerned, and many of the data you will see that age also plays an important role in treatment decisions. So the risk stratification, again low risk, we have disease confined to the endometrium, and overall they do very well, and they might not even have a local recurrence, so may not have much evidence to support adjuvant therapy in this patient, and at least from the previous talk also it's been sort of clear now we should not treat them. When they look at the intermediate risk, this is sort of a controversial and sort of confusing area because it's confined to the uterus, but we have a lot of adverse prognostic factors which actually will divide them into high intermediate and low intermediate risk, and we really are not very sure how actually we are going to treat them. Radiotherapy is mostly there, but where are we going to place chemotherapy? Should chemotherapy be given to all? These are the questions which need to be answered. This is because intermediate risk patients have risk of locoregional relapse in most of the trials that has been shown in the previous talk, but overall they are at low risk of distant metastasis, but it cannot be generalized. More and more we come to know that in high risk intermediate also we have a significant chance of patients. I'll show some data where they will be actually be failing beyond the pelvis. So some clinicians do offer adjuvant chemotherapy in this high risk intermediate category, but again that is not much of evidence based, which I'll come to later. High risk, most of us we think that it is sort of clear that we should give chemotherapy regardless either it's a histology or grade, and also because it's high risk of relapse and death from the endometrial cancer itself, and majority of them we know that relapse beyond the pelvis, and most of them die due to systemic metastasis, and they do receive adjuvant chemotherapy. I will show some slides which shows that is that also really evidence based. However, we know that even in high risk, most of us will be treating with either chemotherapy or radiotherapy or sometimes both. We really are not sure how to sequence it and how best it is going to benefit our patients.